Good morning. This is Dr. Sree from Chennai, India. Today I am presenting my session titled Safer Nicotine, the Potential for Change in Developing Communities. My work belongs to migrant population, especially interstate migrant construction workers. In the past 1 year, I have been working with them, understanding their tobacco consumption practices, attitudes, and behaviors towards consumption of any low risk alternative products. So, to begin with, if you can look into this, migration has been recognized as a global phenomenon, and in India, especially, we have 440 internal interstate migrants, and Tamil Nadu is one of the major destination site when it comes to the migrants coming from North and Central India towards South India in search of employment opportunities. And construction sector in India alone employs 46 million workforce, and in South India, especially Kerala state, Karnataka, Tamil Nadu, and Andhra Pradesh are one of the major emerging destination sites for this migrant population to be employed in different sectors including construction sector. And if you look at the migration and tobacco issue, it looks like it is an epidemic in making in explosive numbers. As you can see here, it appears very clearly that migration and tobacco are also interlinked. When you look at migration as a global public health priority and interplay of disparities of socio-economic and cultural influences determined as social determinants of health, and migrant populations are recognized as vulnerable population groups. And among these migrants, if you look into the tobacco, the influence of the migration alone is playing a major role because migrants are having double the numbers of tobacco consumption practices compared to the national average, and also they have higher rates compared to their own native states. So it is like a double important issue. Their numbers are higher than the national average, and their numbers are also higher than their own native states. So when you put these two pictures into perspective, it emerges like migration is acting as a key determinant in their influence on tobacco consumption practices. And there are also a lot of studies which have clearly established that migrant populations have limited access to prevention and therapeutic health services because of their movement, and they don't have a residential proof, and they cannot access the structured systems in the hospitals because of language barriers, because of poor understanding of the local culture. And with this background, I approach this topic as a synergy of public health priorities in India, especially linking the universal health coverage, which has a doctrine of leaving no one behind, and linking it with migration health and again towards tobacco comprehensive services. And with this background, if I propose that if we address this issue as a systems science approach, basing it as a population driven study, and uh, integrating health system strengthening as an essential element to deliver services, and leveraging the institutional partnerships in this connection, both the private sector and the government sector and the NGOs, they can have effective partnerships in addressing this issue of tobacco among migrant population. And bringing the mandate of WHO and FCTC framework, we can aim for a tobacco free campaign aimed at vulnerable populations. Generally the campaigns are targeted at national level for general populations, but looking at the significance of the migration population and migrants and tobacco issue, we need to have a separate campaign designed at tobacco free campaign towards these vulnerable population groups including migrant population. And we need to evolve certain new systems wherein we have to move away from hospital based systems to workplace based service delivery models. And with this kind of approach, I foresee like we can bring some kind of innovation in delivery of services so that this tobacco epidemic among these vulnerable populations can be adequately addressed. If you look at my field practice area, I work in a private medical college as a professor in the Department of Community Medicine, and we have two geographical sites attached to our rural and urban health centers. In that particular field practice area, according to this Google map, You can appreciate the concentration of this construction activities as can be seen in red balloons, and there is so much of concentric activity happening in the suburbs, whether it is commercial or residential construction projects, and major big projects are identified and are concentrated in these two localities. So, with this background, in the past 1 year, I have covered almost 40 construction sites, and I have reached out to 4,000 migrant populations with general health services for the common ailments, infectious diseases, and other services. But tobacco specific targeted services are provided to approximately 1,000 migrants in this span of 1 year. And if you look at the results, as you can see in this results, it looks like the results are very clear here. The median age of the migrants appears to be 26 years, and majority of them are coming to the uh, Chennai, especially in less than 1 year. And their smokeless tobacco habit looks to be predominant, and followed by smoking and dual users. When it comes to the awareness of low risk alternatives, it looks like almost 99% are not aware of any other alternatives than the product they are consuming, whether it is a smoking form of cigarette or BD or smokeless form like Kaini, Gutka, Pan Parag, and Zarda in India. It looks very clear that they are not aware of any other alternative for risk products for tobacco. And if you look at their health seeking behavior, it looks like they have poor health seeking behaviors, and their reach to the hospitals for any tobacco specific services looks very much minimal. And coming to the safer nicotine choices, the topic allotted to me today, the safer nicotine choices and the scope or potential in developing communities. When you talk about India, the safer nicotine choices available to the Indian population who are like adult tobacco users in any form, it looks very clear that the only choice they have is nicotine replacement therapy. There's nothing beyond this, and nicotine replacement therapy products such as gums, lozenges, and other newer products which came into the market, they all have certain barriers to be included, and these new products which are available on the online markets are not accessible to all populations. And coming back to the barriers of safer nicotine, the two major issues I can pinpoint my talk are about accessibility and affordability. When you talk about affordability, in a population group like migrants or low wage earning populations who are the majority contributors for tobacco epidemic in India, the question of having accessibility to safer nicotine products is hugely challenging, even if they are able to access because of health education campaigns or awareness campaigns or mass campaigns. The affordability comes into the picture, and it is a major detriment and also a major determinant factor for them to actually use safer nicotine products. If you look at the market prices in India, 10 numbers of nicotine gums can cost anywhere between 100 rupees. 90 to 100 rupees is the minimum price range where 10 gums are available for consumption among people who wants to have a safer alternatives. But among the majority of low wage earning and low income group populations, spending 100 rupees is beyond their reach. So there is no question that they'll go and buy the safer nicotine products and use it because they have awareness and because they have intention, and because quitting tobacco may not be feasible for them. So, addressing this affordable factor is very important if in India we have to make a major shift towards safer nicotine choices. And coming to the accessibility, again, these products are not available in the government sector hospitals at free of cost or even at discounted prices. So they are exclusively available only in private pharmacies, and people have to go to the private pharmacies. They may need a prescription or over the counter also they can buy these gums, but how many of them can actually go and reach these private pharmacies and ask for nicotine safer nicotine products? That again is a glaring gap when we talk about accessibility and affordability factors in safer nicotine products in India. Unless we address these two issues, which are major going forward, I look at it like if you have to address this issue, you have to talk about product innovation And when it comes to product innovation, we need to keep in mind the economic factors. Whatever new products are being considered for Indian market and Indian tobacco adult consumers, they have to keep in mind the low cost factor, because for masses, almost like 300 million tobacco users in India, we need to talk about how can the price be an important factor, so that it can be made accessible to these populations. Price should be within the reach of this population, so that they can go buy and consume these safer alternatives. Otherwise, the other choice is you can make them available as a social marketing approach. Earlier in India, we tried to market these products like ORS, oral rehydration solution, and iodized salts, and even condoms for promotion as a social marketing approach. Similar approach can be thought about in India, where you can market these low cost, safer nicotine alternatives, either nicotine gums, lozenges, patches, or strips, so that wider population groups can access them at a low cost, affordable cost, consume or use them as an alternative. So we need to think for such innovative implementation policies. Otherwise, addressing safer nicotine choices for Indian population, Indian tobacco users, remains following the same old tradition of, quit or die kind of approach, which is not at all possible. And we have to think of innovation, and we also have to think of alternative care delivery models, because predominantly right now tobacco control is restricted to medical colleges, teaching hospitals, government hospitals, in niche segment of private sector hospitals. We need to dismantle this particular system and make it more reachable to the common public through community based tobacco cessation support delivery model. So we have to bring this entire setup, entire range of services related to tobacco within the reach of common population through primary health care center approaches and other innovative community involved, community engaged, community run initiatives, where people can actually deliver the services with quality training, and making these products available at such doorstep level. And coming to the health policy, right now in India, there is no policy towards safer nicotine products at all, because recently in the last year 2019, the government of India has banned electronic nicotine cigarettes, which are considered to be a safer alternative, at least for the upper economic sector. But because of the ban in place, right now there is no national policy reflecting the safer nicotine choices as one of the prong in tobacco control and cessation services. As a researcher, as a public health specialist working with tobacco and working in migrant population, my sincere request and humble request to the government of India is to incorporate tobacco harm reduction as one of the main branch of executing tobacco control a national program. And within this tobacco harm reduction policies, there should be a clear mandate for safer alternatives, especially low cost, low priced, wide range of safer nicotine products to be made available for women consumers, vulnerable population groups including migrant population, LGBTQ plus, transgender population, because these are the pockets of vulnerable population who generally miss out in the national policies, because they are catered towards general population. Unless we focus special attention towards these vulnerable groups including migrant population, and design specific interventions to reach to them and target them with this safer nicotine choices and prevention and education messages, we may not be able to tackle the tobacco epidemic in its entirety in India. And that is where, as a researcher, and my participation in global forum of nicotine is aiming me and guiding me and directing me towards thinking what can be the population level strategies, and what can be the marginalized and vulnerable population focused strategies, and what can be the recommendations from the field we can carry forward towards policy making in India. So, with this background, I can only hope that wider consensus has to be arrived, and wider consultations have to be happening in India to address this issue. And global experts and the forum like Global Forum of Nicotine can focus more attention in developing communities, including India, Pakistan, Sri Lanka, Bangladesh, and other parts of the developing world, and put some international focus on Indian and other national policies, which can make a shift from the existing framework towards innovative frameworks. It can also highlight the issues related to the cost and related to the accessibility, related to the reach of the common population for these services. Unless we focus direction in that way, I think we will be remaining as we are, addressing the issues at a superficial level without understanding the ground realities. And we need to highlight this through this forum. And my presentation gives me an opportunity to share my work experiences with the global audience. I'm extremely committed to work towards migrant populations, and I'm trying to make all the available resources for me to address this and bring more focus into this. So, to conclude, there is a lot of scope for safer nicotine choices in developing communities and countries, including India. The second point I would like to highlight is we want more consultations involving multiple stakeholders: the policymakers, the consumers, the advocacy agents, researchers, public health agencies. We all have to come together to talk about safer nicotine choices in developing countries. And unless we make it as a main agenda to be incorporated into the national policy development and designing, this issue will always remain unaddressed, and we need to tackle it urgently. Thank you so much for this opportunity, and I thank GFN 2020 for giving me this wonderful opportunity as a speaker. Last year, I had been here as a participant, and it motivated me, inspired me beyond my imagination. I went back and had done a lot of work in tobacco and emerging as a tobacco scholar in India. And I thank once again GFN for giving me this wonderful opportunity. Thank you.